Hello and welcome to Health Econ on the Go, your favorite health economics podcast where we discuss articles and more. I am your host, Ogun Cano, and joining me is my co-host, Matilde. Matilde, how are you?
Hi, Ogun. Very good. Very happy to be here. It's always a great moment when we recording this episode. So I'm here, very excited. How are you, Ogun?
Amazing, Matilde. Glad to hear you're having a good time. Well, I'm very good. I'm in Mexico, currently enjoying some well deserved holidays. We are celebrating Independence Day here in Mexico, so everything is very quiet, everything is very much relaxing. So, what's better than relax to talk about health economics, right? Our passion.
Yeah, no better way to relax. Did you do anything special for the celebrations?
Well, I wasn't aware of the celebrations until 2 weeks ago when a friend asked me, "What were you going to do?" And I was, "Oh, well, it's a regular weekend." And she said, "No, it's going to be a full holiday weekend." And then I recall, "Oh, yeah, that's true." So no big plans for me, just relaxing, staying at home, watching a couple of movies. Yesterday, watching American football, which is a big hobby around. So that's it. That's it. Staying with the family, visiting some friends, and I think that's it.
Great. In our side, we ate some tacos yesterday, which is an event here in Belgium for us.
Yeah, I imagine I
That
saw
was a
some.
celebration.
Very good, Matilde. Very good, Matilde. So,
Okay.
again, thank you all for listening to us. We are already past mid-year, so we're fast approaching the end of the year. So, again, thank you very much for spending time with us and discussing health economics. Matilde, you want to kick in?
Yes, and let's get started. So, for my non-peer review, I'm gonna discuss something about big companies, big soda company, and sport. So, do you remember when Cristiano Ronaldo moved those Coke bottles out of the side at a press conference? That tiny gesture wiped 4 billion of Coca-Cola market value overnight. So, in this segment, we will be diving in the growing movement against big soda's grip on sport sponsorship. Be breaking down insights from the Lancet, the BMG, NPR, and the Global Health Now. Don't worry, all the links will be in the podcast description. So here is a scoop. A new campaign called Kick Big Soda Out of Sport is gaining traction. It's targeting companies like Coca-Cola and the century-long partnership with the Olympic Games. Yep, you heard it right. Coca-Cola has been linked to the Olympics since 1928, so almost a century. But in 2023, Coca-Cola didn't just dominate the field. They outspanned Nike in sport sponsorship. It's pretty impressive. And what's the cost? Why is that an issue? So here are the facts. First, there is a health angle, as we are a health economic podcast. For example, in 2021 alone, sugary drinks were tied to over 3.6 million years of healthy life lost and more than 75,000 deaths globally due to the link to the diabetes, to hypertension and cardiovascular issue and obesity. So we're definitely not talking about the picture of health here. Second, the environmental impact of those companies. Beverage companies and fast food companies, including Coca Cola, are the leading contributors to single use plastic waste, which is terrible. And then there is another kicker. According to the BMG, when Coca Cola sponsors global events like the Olympics, they're not just splashing logo around, they're gaining access to influential circles of corporate and political power, using it to push their agenda. Lastly, let's not forget the target audience, kids. By targeting them and making publicity to kids, they some of the most influential population. And despite promises to limit marketing to children, Big Soda continue to advertise directly to the most impressionable audience. It's all sugar-coated, but the consequences are serious. So, what can we do? You can join the movement if you think that's an issue that we shouldn't be linking Coca Cola to something as the Olympics or any other sport. There is a petition calling for an end to the big soda sponsorship in sport. and starting with the Olympic. You can sign it today and take a look also at the fact sheet breaking down all those critical issues. Link in are in the podcast description if you want to read more about and if you want to sign. So yeah, that was my section of non-peer review papers.
Very good, Matilde. I think this is an urgent call. Growing up in Mexico, I think is quite common to see Coca-Cola being advertised everywhere. And as a kid, I think it's very, very normalized to also see Coca-Cola in the football matches. You see it in sports like baseball because you see it all around. But as you start to grow up and you start to see the connections between chronic illnesses and specifically beverages, highly sucrated beverages, it starts to ring a bell, right? That doesn't make sense. And then you realize it's also a big sponsor in the Olympics. And I think this sponsorship, as you mentioned, goes back to almost 100 years. Really makes you ask questions, right? So from what you review and what you read, how likely is that this will actually happen? Because money moves interest, and there's a lot of money between Coca-Cola and sponsorship in sports.
Yeah. For example, the McDonald's was also a sponsorship for the Olympics, and there, I think in 2017 or around the time, they were able to cut that sponsorship through the a movement a bit similar to the one that's happening now. So there is some hope, but also the money behind it is so big, and because of the impact it has, the good impact it has for Coca-Cola, so all the money they're making out of it, they're not gonna, yeah, let it go so easily. So thankfully, there is loads of organization from around the world, from Mexico, the public health institution, as from Australia, so from the UK. So hopefully, I found there is 93 partners currently for that campaign. So let's hope with if we all unite, we can make it.
Very good. Thank you for sharing, and I hope our listeners can also join the petition. I haven't, so I will after we finish recording today. So moving on to our next part of the episode, I'm going to discuss my first article. It's called "The Impact of Energy Poverty on the Health and Welfare of the Middle Age and Older Adults." This was published this year in the Frontier Public Health Journal and is authored by Jaibo Wang and collaborators. So this research focused on a poorly discussed topic, which is energy poverty. So it's a problem that is disproportionately affecting older population, especially in China, where the what is the setting of this study, impacting their health and overall well-being in ways we're only beginning to understand. Well, there's no a universal definition of what is energy poverty. It generally encompasses situation where individuals or households either cannot afford to keep their homes adequately warm or cool, lack access to modern electricity services, or rely on traditional biomass energy sources like firewood, straw, or animal dung for cooking and heating. The study will be based on data from the 2018 China Health and Retirement Longitudinal Study and is using two key measures to assess energy poverty. The first one is called the Multidimensional Energy Poverty Index, the MEPI, that is considering factors like cooking, like the fuel type you use for cooking, the electricity access, and ownership of appliances. The 10% threshold indicator is the other measure they use, and this is classifying households as energy poor if they spend more than 10% of their income on energy services. What grabbed my attention from the result is the widespread nature of energy poverty among this demographic population. The research found that 44% of middle aged and older adults in China are affected by energy population. And because China is this big, this isn't just a statistic, it represents millions of individuals struggling to meet their energy needs. For those that are looking for more information in the methodology, I think this is a very sophisticated study that is including an OLS regression methods, the ordinary least squares, and other that is less well used in widespread methodology, but it's also quite robust. That is the TSLS, the two-stage least squares estimation, and in mix using both, we're going to address potential endogeneity issues. The research also conducts robustness checks by replacing core explanation variables with alternative measures of poverty energy. That if you want to read more, I invite you to read the article. This study is revealing a significant impact on both health and welfare effects. Those experiencing energy poverty are more likely to report poorer health outcomes and lower life satisfaction. The health impacts are particularly concerning. Energy poor households often rely on traditional biomass and coal for cooking and heating, leading to indoor air pollution. This exposure significantly increases the risk of respiratory diseases, cognitive impairment, and cardiovascular issues. On the welfare front, this study uses life satisfaction as a proxy for overall well being. While there might be some caveats, I think the conclusion is remarkable. The findings suggest that energy poverty exacerbates disparities in quality of life, affecting aspects such as leisure activities and social interaction. In the end, I also like that the study proposed some policy recommendations, including enhancing energy services for older adults in rural areas, integrating household energy alternatives with targeted poverty alleviation, and conducting energy education activities. And that's it for my end.
Okay. Oh, thank you for sharing. When I saw first the paper, I was like, "Yay, that's super interesting." It's very important work as yeah, the broader determinants of health are important and sometimes bit more for forgotten maybe or not as directly linked to health. And the issue, yeah, of poverty for the energy poverty is sometimes something, at least from the Belgian perspective, cooking with coal in the kitchen, not as common. But I remember Mexico having quite a lot of patients that were still cooking like that. So yeah, quite important work. Thank you for sharing. Could you a bit delve a bit more into the policy implication of this paper?
Yes, and in your comment, you really address it. Is the social determinants of health. So therefore, this answer is not easy. It represents a more broader aspect other than health. But I think we can summarize it in 5 or 6 points. Number one, as the conclusion said, enhancing services in rural areas to increase access to clean energy and modern appliances. Then integrating household energy alternatives with targeted poverty alleviation efforts, including subsidies for cleaner energy sources, therefore incentivizing the use of more clean energy alternatives, establishing graded monitoring mechanisms to address regional disparities in energy poverty, then conducting energy education activities to raise awareness about the benefits of clean energy and efficient use. And I think this point is so important not only for energy poverty, but as a whole. Education has been demonstrated to be one of the long-term sustainable policy things we can do in the broader spec of outside of only health. So education in this matter is so important. We're talking about rural areas where people are less likely to be more educated. So if we can bring some kind of information about energy alternatives and the impact of health, that's the hope that people will eventually take care of themselves in this front. Improving energy infrastructure in rural areas, tailoring solutions to local conditions, for example, biogas, solar, wind power, depending, right? And in the end, I think considering energy costs when setting poverty lines to break the cycle of energy related poverty, as people rely more on low grade energy fuel, therefore increasing their likeness of having an illness, therefore increasing their costs and less money available to use for alternative and cleaner resource and energy alternatives. So yeah, kind of break that cycle. Again, it's kind of complicated because it's not only on health, but I think these points highly are remarking the policy implications.
Yeah, yeah, it's true that it's not an easy solution. There is not like, oh, let's do this and it's finished. We cure energy poverty. But it's interesting having all those point of view and including the education, which obviously is crucial. Well, connecting a bit with those with this paper on talking a bit more about the social and the broader determinant of health, I have my next paper, which is called Cost Effectiveness of Group Medical Visit and Microfinance Intervention versus Usual Care to Manage Hypertension in Kenya, a secondary modeling analysis of data from the bridging income generation with group integrated care. So it's quite a mouthful as a title, pretty long, but a very interesting paper. So today I'm excited to discuss a fascinating study. Cost effectiveness analysis of the big peak. As I mentioned before, it's bridging income generation with group integrated care trial in rural Kenya. It was funded by the National Institute of Health in the USA and published in the Lancet. These research stand out because it examines interventions that address broader determinants of health by tackling poverty, which is a root cause of disease and a crucial aspect often overlooked in health economic study. Although, yeah, on the side, I think in this podcast we've been trying to focus on the study that look at those issues, so it might not be as overlooked in this podcast at least. So this innovative study evaluated the integration of group medical visit and microfinance intervention with usual care for hypertension management. The results are compelling. Both group visit and a combination of group visit with microfinance could be cost-effective strategy to improve blood pressure control in Kenya. To illustrate, group medical visit costs just $7 more per person than usual care and adverted 0.00 more DALIs, with an incremental cost effectiveness ratio of $1,455 per DALI adverted. More impressively, the combination of group visit with microfinance demonstrated a remarkable synergy. While costing $37 more, it adverted 0.014 more DALIs with a nicer of $2,601 per DALI averted. This synergetic effect potentiated each intervention, resulting in a greater benefit than the sum of their individual aspect. So we are averting more DALI by doing microfinance with the group medical visit than the number of DALIs we are adverting by doing just the microfinance of just the group visit and then summing those. So they have like together they potentiate each other, which is I found very interesting. Fascinatingly, the cost effectiveness differed by gender. It's also to note that in this study there were way more women than men, suggesting that a gender-based implementation strategy could be optimal. Using a Markov model to simulate health state and cardiovascular event over 10 years, the analysis found that the results were most sensitive to the intervention effect on reducing cardiovascular risk. At a willingness to pay threshold between 1,000 to 3,000 per DALI averted, dollars per DALI averted, which is 1 to 3 times the GDP per capita, group medical visits were most likely to be optimal, while above $3,000 per DALI, the group medical visit joined with the microfinancing was most likely optimal. It is worth noting that while this study focused on health benefits, this intervention might have additional social and economic benefits that were not captured here. So these findings suggest that integrating group care and microfinance with usual care could be a cost-effective approach to improve hypertension management in rural and low middle income settings. However, policymakers should be careful and also consider gender differences when selecting implementation strategy. These studies serve as a powerful reminder of the potential impact of addressing broader social issues on health outcomes.
Thank you, Matilde. Yes, we should, instead of doing our usual PubMed or other databases with keywords, I think we should just say whatever title with more than 50 characters, we accept it. Or 100
Yeah.
characters, something like that, because the titles are usually that long. Uh,
Yeah, the longest title, the better the article, no?
exactly. Yeah. On a more serious side, on top of what you mentioned, I think one also aspect that I want to bring attention to our listeners is the gender differences that the study found. Somewhere in the articles mentioned that women may benefit more from group medical visits due to a greater comfort in group settings, willingness to discuss health issues openly, and tendency to be more proactive about seeking healthcare. Men, on the other hand, are going to gain more from the microfinance component because they're often primary financial decision makers in households, especially in rural Kenya. I know this doesn't apply to the whole world, but especially in rural Kenya, men are more responsible for the financial stability of the house. Therefore, the social support and education aspects of group visits may particularly resonate with women, while access to microfinance could empower men to allocate resources toward healthcare and medication. So I think this also underlies that assumption that we always do or remark that one pill doesn't fix everything, right? So we need more tailored solutions, and I think this is a good example. The authors mentioned that their analysis focused only on the health benefits of the interventions. However, they also suggest that group medical visits and microfinance might confer additional non health benefits. Could you elaborate more on what of some of those potential health benefits mean?
Yeah, and you're right. Like they did point out, and that they're mainly focusing on the health benefits. But group medical visit and microfinance intervention likely have several non-health benefits that weren't captured in the cost effectiveness analysis. For example, for microfinance, this potential benefit includes improved economic well-being, increased empowerment of female participation, can also include reduced HIV risk behaviors. So microfinance initiative could also improve access to financial credit for vulnerable position, potentially reducing financial barrier and improving overall healthcare access beyond just hypertension management, really opening. And the group medical visit, on the other hand, might improve trust, social support, social cohesion among community members. This social benefit can have a indirect positive effect on health and well-being that extend beyond the specific condition being treated. So the combination of both strategy could potentially complement each other, resulting in further improvement in overall quality of life. So these non-health benefits were included in the cost effectiveness analysis, primarily because they're challenging to quantify in monetary terms or translate into dollars. Including them would have required making many assumptions and could have introduced even more uncertainty into the analysis. However, the author acknowledged that future analysis should aim at understand and incorporate these total health and economic and social benefit to provide a more comprehensive picture of the intervention value.
All right, thank you. Yeah, that makes sense. They're very complicated always to integrate into these economic models, right? All right, so moving on, my second article, it's not titled as long, so I don't know about the
Oh
quality of
no.
the study. It's called Cost Effectiveness of AI for Risk Stratified Breast Cancer Screening. It's published in the JAMA Network Open Journal and is authored by Harry Hill and colleagues. It's not that long of an article, and you will hear some caveats that I have for the article. So this research comes at a crucial time, I think, as healthcare systems worldwide grapple with resource constraints and the need for more efficient screening programs, particularly in these chronic conditions like breast cancer or cancer as a whole. The UK National Health Service, like many others, is considering integrating artificial intelligence into breast cancer screening to improve outcomes while managing costs. The study is going to employ a sophisticated decision analytical model to assess the potential economic impact of incorporating AS AI-based risk basement into the UK breast screening program. Sorry about the confusion. It's an AI-based risk assessment into the UK breast cancer screening program. Currently, the general rule is that women aged 50 to 70 are invited to for mammograms every 3 years. So this is the whole normal package. The research is going to compare this standard approach with four AI guided strategies that adjust screening frequency based on individual risk profile. The AI that they use is going to be named Mirai. What sets Mirai apart is its ability. This is a healthcare focused AI, Mirai. It's its ability to provide an immediate estimation of short term breast cancer risk following a negative mammogram without needing additional data collection. This model is going to interpret data automatically generated from mammogram screening, offering a more efficient and potentially more accurate risk assessment than traditional methods. The study others went as far as to consider Mirai to be arguably, quote, the best retrospectively validated AI model for short-term breast cancer risk assessment. Quite specific. I have some comments that I will tell at the end. For the findings, we have that all four AI-based strategies not only improve health outcomes but also reduce overall cost. The most effective approach involved annual screening for high-risk women, biennial or triennial screening for those at medium risk, and screening every 6 years for low-risk individuals. So it's either from 1 year to 6 years, the spectrum of the recommendation. This strategy could potentially save the NHS up to £85 million annually, while preventing more than 800 breast cancer deaths also annually. What's particularly noteworthy is that these findings persisted even under conservative assumptions. When the value of a quality adjusted life year was set at just £1, the AI guided approach still generated savings of £10 million per year. The use of Mirai in this context represents, I think, an innovative approach, of course, to personalized breast cancer screening, which is something that I think the whole industry is moving towards more personalized medicine. I think breast cancer is an excellent starting point. Leveraging AI technology to potentially improve the efficiency and effectiveness of screening programs. I like this article. Again, it's not that long of an article, so if you have time to read it, really dig in. And I hope that in the end you will end up like me saying, okay, but what is Mirai? How does it work? How does this analytical model actually works? And I think they don't want to give out a lot of information to, I don't know if there's a lot of competition. I assume there is. This is technology, so there's always this kind of very rough competition. But it's not like ChatGPT, it's not like Baldo. I don't remember what is the other AI's name. It's not like Gemini that you have so much information. I think for Mirai, I don't know if even this paper should be published. I think it's interesting from the economic perspective, but there is so little information about Mirai from what the article is discussing that I'm still skeptic that this will hit the NHS or any other health program in the near future. That's my only negative take. I think methodologically, the study is quite robust. The findings are very interesting. And I think this is just the top of the iceberg in terms of what is coming in the future in terms of AI.
Yeah. Yeah, you're right. Also, there is, I think, with those AI technology, a bit of question about the patient data and how it is who is own them. No, if it's going through a software, yeah, how do we keep the privacy of the patient and all those questions that need to be answered around the AI and all those new technology entering the health space. So that's one of the big talking point, I think, the iceberg for this year and the coming one. That how do we manage those technology? How do we make them accessible for everyone, not only the rich countries or rich people having access to them, and how we protect patient data when we use them. So that's big consideration with those papers and those technology, no? And a bit more on the health economic side, looking at the model a bit, and they present a diagram. So what happened to the patient which receive a false positive from the mammogram? Because they don't dwell as much, at least in when they present the diagram. So what happened with those patients?
Yeah, that's an excellent question. And you also said it right. They don't dig that much. So the way I imagine this working is as a thoughtful detective. The AI is a thoughtful detective that is going to carefully consider every aspect of false negatives, false alarms in mammogram screening. Very importantly, this AI is going to recognize that these false positives aren't just numbers; they are experience that affect real people. And this is one of the key aspects that I enjoyed reading, but I also want more information. So now I'm like hanging in there, right? The model is going to estimate that false alarms happens about 1.5 to 3% of screenings, depending on how dense a woman's breast tissue is. It also acknowledges that this false alarm can be stressful, temporarily reducing a person's quality of life by a small but measurable amount. Very important, this aspect. On the practical side, the model is going to factor the cost of follow-up tests, nearly £500 for false negative, for false positive, sorry. It's like tracing, right? The ripple effects of a strong tone into a pound. The model It's going to follow false positives through the entire screening journey from the first, this looks unusual, right? Moment to any follow up discussion or biopsies. It's particularly interesting in how AI might change things, comparing each AI strategy to the current approach of two radiologists reviewing each mammogram. Interestingly, some AI strategies show promise in reducing false alarms. For instance, when AI worked alongside one radiologist, it led to 4% fewer unnecessary recalls compared to the standard two radiologist approach. Looking ahead for the research plan, the authors mentioned that they are going to do a follow-up test for 23 months to get an even clearer picture of how these strategies perform in the long run. So I think by considering all of these factors, the model is trying to capture both the emotional impact and the healthcare costs associated with false alarms, while exploring how AI might help refine the screening process at various stages. So very interesting.
Okay, yeah, thank you. And it's funny that you also mentioned that usually there is a doctor or a technician working alongside the AI, because I remember from the iSport when they were talking about AI technology, they said most doctors agree and are okay with introducing them in the healthcare setting, but not to replace them, to work alongside them and potentially improve the work they do. So it's really interesting to see again this model appearing here now of working with AI and not having it replace the doctor.
Yes, that's true. Good memory.
So thank you for sharing this. And it ties up. I think we have something about women's health in almost every episode no? Now.
Yes.
So that's pretty cool. Very important. So before we wrap up, it's time for the fun note. But this time we have a comment of Ogun about this last recommendation. So Ogun, what do you wanna tell us?
Oh gosh, I feel in the spot. So before recording today's episode, I actually went back to hear what I said about the last book that I recommended that was called Limitarianism about, well, called Limitarianism, and the author is Ingrid Robbins. So shortly there she's talking about limiting wealth how much wealth a person can have during their life journey. So that's it. And during the last podcast, I mentioned that I was going to take a leap of faith, recommending a book that I haven't finished. That's the last time I'm going to do it, and not because I believe that this book is fundamentally wrong. I think it's morally correct, but what I'm more concerned about is that I'm quite a skeptic about some of the conclusions. I'm not going to spoil anything. Again, the conclusions have been discussed elsewhere. So I think the author is too optimistic regarding wealthy people voluntarily redistributing their wealth. So for me, the optimism for the future does astound me at times, the Robbins optimism. And also, I don't think it's possible to objectively determine the wealth limit that encapsulates what it's needed to have a flourishing life. I think that's the main aspect. How to get to that, threshold of how much a person can have. It's quite arbitrary, and it was more or less related to a, it's not an interview. It's more like a survey of asking people, do you think this is enough? Do you think this is enough? And well, not everyone answering that question owns more than €1 million in their bank account. So of course they're going to say, yeah, that's a lot. And I'm not pro wealthy people. I'm just saying it's very difficult to establish that threshold. Even if you talk about the high threshold or the low threshold, it's quite arbitrary. And I think without the policies implementation and the willingness to implement those policies, I think it's going to be very, very difficult. Again, the book is not fundamentally wrong. I just think that it's quite complicated to actually make it happen. But as a topic of discussion, I think brings a lot to the table, especially the new concept of limitarianism, because the book also doesn't talk about too much about what's the negative side of it, but I think it's more because this is a new concept. So more to come, I guess.
Okay, thank you. Thank you also for having your complete opinion. So we don't have just the first few pages, but the full book of your opinions. That's very, very good. So for this month, we're spotlighting a podcast, and for it, I decided a podcast called This podcast will kill you. It's from the Exactly Right network. It's a bit more on the funny side, but it's for anyone that has some interest in health, which would imagine that anyone listening to this podcast is, and that want to listen and being a bit more light, although, yeah. So don't worry, this podcast won't actually kill you, but it does cover a wide range of things that could. Each episode takes a deep dive into different diseases, exploring its history, biology, and answering the big question: how scared should you really be? So the hosts, Erin Welsh and Erin Alma Updike, are both ecologists and epidemiologists with PhD. So they have a very scientific background. And they have an amazing talent for making infectious disease not only fascinating, but also somehow a dinner party conversation material. And the bit of extra, the cherry on top, is they include a team cocktail recipe for each episode. So you get a bit of everything. Erin Welsh is now a full-time science communicator and a bourbon and sour beer enthusiast, while Erin Alman Updike is wrapping up her medical residency and loves pink wine and pale ales. Together, they make learning about disease both entertaining and educational. So, hey, if you're into podcasts, which I hope you are if you're listening, and if you're in podcasts that explore diverse topic, you'll be in the right place. This podcast covers loads of subjects and even has a book club with some amazing recommendation. So today, well, on my way to pick up my son from nursery, I was listening to their episode about roads. Roads is, I think it's called Crossing, and it's one of the one where they discussed the book from the book club and how roads have an impact on the way that we structure our life, and they will have an impact on our health and the ecosystem around. So it made me see my daily commute in a whole new light. So yeah, if you're looking for some fresh perspective and maybe a drink recipe or two, just go give the This Podcast Will Kill You a try. Yeah, you might enjoy it quite a lot.
Very good. Great recommendation. I've heard the title before. I never actually heard a single second of that podcast. And I think the first lesson we can learn is to name our podcast in a clever way. So probably we will change the name. Not 50 characters long, but something a little bit more more clever and friendly. Very good.
Yeah, a bit more
Um,
entertaining.
Thank you very much, Matilde, and especially thank you for staying to the end of this podcast. We will hear each other next month. As usual, if you find this information interesting or you think one of your colleagues or friends might benefit from hearing us, give us a share, give us a like. That helps us a lot. And if you have any comments, any suggestions, any interviews that you would like us to do, don't hesitate to send us a message or leave a review in your favorite podcast provider. Thank you very much, Matilde.
Thank you, Ogun. Such a pleasure to see you. And thank you, everyone, for listening to us. Have a lovely end of the month. And see you
Bye.
next month. Bye.